Hello and welcome to my talk entitled Genetics of Hearing Loss, Core Concepts, Communication, and Collaborative Care. My name is Amanda Schaefer. I'm a licensed and board certified genetic counselor specializing in hearing loss and deafness genetics at the University of Iowa. I work within our clinical otolaryngology department and provide genetic counseling on hearing loss and deafness, and have a role in the laboratory through the Molecular Otolaryngology and Renal Research Laboratories, or MRL. In my clinical and laboratory work, I am passionate about helping patients and families and healthcare providers understand and use genetic information about hearing loss in their everyday lives. I'm so excited to share some information and hopefully some exciting cases with you today. Here are some of my financial and non-financial disclosures. The objectives of our talk today are to summarize the current understandings of genetic etiology of hearing loss, to describe the process of genetic evaluation, including genetic testing, and how this can help you address patient and family questions and concerns, and to recognize the role of genetic testing for hearing loss and illustrate ways that this could be incorporated into your audiology practice using some case examples. We'll start by addressing some current and knowledge of genetic hearing loss. We'll talk then about the genetic evaluation process and the importance of communication and counseling. Finally, we'll address collaborative care and how genetics can be incorporated into audiological practice. So first, let's review some core concepts about our current knowledge of genetic hearing loss. I'll introduce you to the first case, a patient that will be visiting throughout today's presentation. And as I introduce this family to you, I'm curious, does this remind you of families you've worked with? Or have you talked with other audiologists who have seen families who have the same questions that this family does? Now, this is a 2-year-old male. He passed his newborn hearing screen and had recently been seen by the ENT. The parents were concerned about sleep apnea. The ENT took a look. Yep, he's got big tonsils. We're going to recommend a tonsillectomy. But as he's chatting with this family, he realizes there's some differences in the speech of this child. And as he inquires, the family says, well, yes, our child was a late talker compared to our other children, and his speech is a little off. So the ENT recommends, while we get that tonsillectomy, let's get a sedated ABR to assess for possible hearing loss in this child. And lo and behold, the ABR does reveal this child has a mild to moderate bilateral sensorineural hearing loss. And the family is very distraught by this diagnosis. They weren't expecting it. They're wondering what it means. Could their hearing loss get worse? A lot of questions and uncertainty. And they're coming to their audiologist wondering what to do and what this means. And I would ask you, well, how would you address these questions that this family has? With that in mind, let's talk about what we know about etiologies of hearing loss. And we know that genetic etiologies are the most common cause of prelingual hearing loss. It's estimated prelingual hearing loss impacts about 1 in 500 newborns. And in countries like the United States, it's estimated that around 20 to 40% of those children will have an acquired or environmental cause of their hearing loss, while the remaining 60 to 80% will have some underlying genetic etiology. The acquired or environmental causes could include things like infections like CMV, prematurity or exposure to ototoxic medications. Today, we'll focus on the genetic etiologies, which can be further broken down into both syndromic or non-syndromic forms. Now, the vast majority of genetic hearing loss is non-syndromic, about 70% of cases. Well, 30% is syndromic. And I remind you that syndromic hearing loss just tells us there's a hearing loss as well as other medical symptoms or physical features present in that individual. Whereas non-syndromic means hearing loss is the only associated feature. What's really interesting, but also kind of challenging about genetic hearing loss is the diversity of presentations. Syndromic hearing loss is seen in over 400 genetic syndromes. And on the non-syndromic hearing loss etiologies, we now know of over 120 different genes that can cause non-syndromic hearing loss. Now here I'm showing data for prelingual onset hearing loss, and you might ask, well, what about a postlingual or even an adult onset hearing loss? Unfortunately, we don't have nice solid data like we do for prelingual hearing loss, but studies indicate that there's a significant proportion of postlingual or adult onset hearing loss that's either caused or influenced by genetics. Knowing that most etiologies of prelingual hearing loss are genetic in nature, it's not surprising that a genetic evaluation is recommended by multiple organizations for people with hearing loss. The Joint Committee on Infant Hearing, the International Pediatric Audiology Group, and the American College of Medical Genetics and Genomics recommend a genetic evaluation for infants and children who are deaf or hard of hearing. And the American College of Medical Genetics and Genomics also recommends an evaluation for adults with hearing loss, somewhat customized based on the age of onset or the hearing loss characteristics. Basically, is there an etiology that has been identified? And if there's not, a genetic evaluation could be pursued. Let's dig deeper into what we know about the genetic etiologies, including syndromic and non-syndromic forms. With well over 100 genes known to cause non-syndromic hearing loss, we might think, oh, is there a way that we could further group or categorize these hundreds of genes? And we can do that in a number of ways, including the inheritance pattern of that gene, age of onset of the hearing loss, the severity or frequencies of hearing that are impacted, and if that type of hearing loss is stable or progressive. So let's start with inheritance patterns. And again, here's that breakdown of genetic, syndromic, and non-syndromic hearing loss. Looking further at non-syndromic hearing loss, we will see that about 80%, the vast majority of non-syndromic hearing loss, is inherited in an autosomal recessive pattern. Now, if I were to ask you, when you ask families you're working with, oh, does anyone else have a family history of hearing loss? It wouldn't be surprising to me, knowing that most is recessive in inheritance, that the most common answer you're going to get to this question is, no, nobody else in my family has hearing loss like I do or like my child does. Autosomal recessive inheritance might look like this if we drew out a family history. Maybe there's only one person or a couple of siblings who have a hearing loss, but the rest of the family history is negative. Might be, well, no one else in my family has hearing loss, or I have 2 children with hearing loss and a third who has normal hearing. In an autosomal recessive pattern, we have 2 copies of almost all of our genes. And in a recessive pattern, both copies of that gene need to not be working normally to have hearing loss. Most of the time, it means that parents are what we call a carrier. They each have 1 working copy and 1 non-working copy of that gene. And by chance alone, both those carrier parents pass on the non-working copy. What that means when you're seeing these families who say, well, how could this be genetic? No one else in my family has hearing loss. you might want to briefly explain, well, we know that for most people with genetic hearing loss, it's not surprising that that based on inheritance patterns, that there's a negative family history. And not having a negative family history of hearing loss doesn't mean that the hearing loss in your child couldn't be genetic. What's another way that we could categorize non-syndromic hearing loss? And a second way that we could do it is what we're going to call the audio profile. When we look at the audiograms of people with this hearing loss, what's the pattern that we see? Interestingly, we can see different patterns based on genetic etiology. And here I'm showing 3 examples. On the left, a low frequency hearing loss, like that seen in WFS1, a mid-frequency or cookie bite hearing loss with the TECT-A gene, and a high-frequency hearing loss with KCNQ4. The takeaway being that non-syndromic genetic hearing loss is not limited by an audio profile shape. We can see a vast variety of patterns within non-syndromic hearing loss. Another way that we can look at or categorize non-syndromic hearing loss genes is by if they cause stable or progressive hearing loss. We know from studying people with different types of genetic hearing loss, like stereocylin, this is a stable hearing loss gene, whereas KCNQ4 causes a progressive sensory neural hearing loss. And we know this from tracking people over time with KCNQ4 that we do see a progression, which you can see here in this graph. I will point out one of the challenges of non-syndromic hearing loss is something we call genetic heterogeneity. And this is a way of saying there are perhaps multiple genes where we result in the same hearing loss phenotype. So let's say we were going to see a patient who had a congenital severe to profound sensory neural hearing loss, and we wanted to say, well, what gene would cause that type of hearing loss? And here's a list of just a few of the genes that could cause that type of presentation. That means in looking at this patient, we cannot diagnose the genetic cause of their hearing loss based on their presentation alone. And genetic testing is the only way to diagnose the specific genetic cause of their hearing loss. Now that we've talked about some of the interesting diversity of non-syndromic hearing loss, let's turn our attention to syndromic hearing loss. Again, we know of well over 400 genetic syndromes in which hearing loss is one of the recognized features. Of course, this presents a number of challenges in talking about syndromic hearing loss, the first being the sheer number of syndromes that we're considering. Now, there are some more common syndromes, and I've listed a few on the screen here that you're likely familiar with. Things like Pendred, Usher, brachioradial syndrome, Charge syndrome. These are genetic syndromes that you might see patients with and be familiar with. However, there are literally hundreds more syndromes to consider, each with their own presentation. And it's not something that we can address all of these syndromes within this time period or even recognize those as providers. However, you as audiologists play a really important role in recognizing some of these more common syndromes and their associated red flags that that you can better guide families for further evaluation with genetics. So what might some of these examples of referral red flags be based on those more common syndromes? That might be looking for physical differences like we see in Waardenburg, 2 different colored eyes or a white forelock. It could include noticing things like ear pits and external ear abnormalities and asking about a family history of similar features, hearing loss, or kidney disease. Audiologists play a really important role as you are seeing these families often multiple times if you're providing repeat care and have the opportunity to bring up some of these things and discuss the recommendations for a genetic evaluation to understand if those are related to hearing loss in that person. A second challenge we have in learning about syndromic hearing loss is variability of that condition. That could be in looking at different families, we see not all people have the same features with particular syndromes. So too can we see variability within the family. People who have the same diagnosis, like brachiotorenal syndrome, but it doesn't look the same family member to family member. In addition, some syndromes can have more overt features that people can notice, but other syndromes can have presentations that are pretty subtle and hard to catch. A genetic evaluation can offer the opportunity to piece together all of these diagnostic clues, like a patient's personal history, family history, their physical exam, particularly for conditions where there's variability or maybe some subtle features. We should also highlight a third challenge, which is one we're going to call non-syndromic mimics. And these are persons who have hearing loss that appears to be non-syndromic, but in fact is actually an underlying syndrome. We might see this especially for infants and children. Consider Usher syndrome, where types 1 or 2, the most common subtypes, present with a congenital hearing loss, which looks non-syndromic. However, later in life, those persons will develop a progressive eye condition. Now, there are a number of other non-syndromic mimics. Things could even include Pendred syndrome, more rare syndromes like Perrault, which causes hearing loss and ovarian insufficiency, deafness and fertility syndrome. We mention these as a challenge and an important thing to note in counseling because these syndromic hearing loss really can be indistinguishable from non-syndromic forms of hearing loss without genetic testing. Now, this offers us the opportunity to identify these syndromes and guide management and follow-up before the onset of those other symptoms. So we've had a brief overview of what we know about current genetic etiologies of hearing loss, most notably that genetic etiologies are the most common cause of prelingual hearing loss and contribute to a proportion of postlingual or adult onset. That a genetic evaluation of deaf or hard of hearing persons is recommended by multiple organizations, including the Joint Committee on Infant Hearing. We've discussed the incredibly diverse presentation of genetic hearing loss, syndromic and non-syndromic, variability in things like the audio profile, age of onset, progression versus stability. We've also started to discuss the fact that genetic testing is the only way to identify a genetic diagnosis for hearing loss in many, many cases. With that background information in mind, let's move into talking about the genetic evaluation process and what that means. And maybe when you've discussed the recommendation for a genetic evaluation, you get questions from parents or have questions yourself about what that process actually looks like. So let's revisit our first case that we introduced earlier in the presentation. And to remind you, this is a 2-year-old male. He's got a recently diagnosed mild to moderate sensorineural hearing loss bilaterally. His parents are very surprised and distraught by this information. They're worried about progression and what this means for this child as he gets older. And I pose the question, well, how do you address this question? If you recall, a genetic evaluation for this child's hearing loss is indicated and recommended by many organizations. So perhaps your response to this is, well, I can't say for sure right now what the future might look like, but one way for us to get more information would be a genetic evaluation, including genetic testing. We've had other families who found this to be a very helpful process in understanding what's going on with their child. I would recommend you go see genetics for your child. Um, and we might introduce the idea that really, as genetics providers, we are just another part of your care team for the deaf and hard of hearing patient and their families, alongside other providers that this patient might already be seeing. Like other members of this team, we in genetics play an important role with a unique set of expertise. A family might ask, well, what are we going to do at this genetics evaluation? And the main portions of that visit include understanding what you are after as parents. What are your concerns and your goals? Gathering some information about medical and family history, performing a physical exam, getting some education and information about hearing loss and genetics, talking about things like genetic testing options, and offering resources, support, and psychosocial counseling. Who will you see at a genetics visit? Can vary a little bit depending on where the person is being seen. Most often, it's a two-person team with a genetic counselor like myself. We are individuals with master's degrees, board certified, and have training in medical genetics and counseling techniques. We work in tandem with either a physician or PA or ARNP. That can either be a geneticist or an otolaryngologist. We work in tandem to see patients. And one of the key differences between a genetic counselor and, say, a physician is the ability to perform physical exams. In that, as a genetic counselor, that's not within my scope of practice. Additionally, if there are medical recommendations or treatments to be provided, the physician or ARNP will discuss those and make those recommendations with the patient or family. So you have, as the audiologist of this person, have referred them for genetics. The family has arrived, and our first thing is to just understand what their goals are. What are their main concerns? And for this family, they really have a concern about possible progression of hearing loss for this child. Additionally, they've done some reading about genetics hearing loss and understand that there could be other health conditions to consider for their child and are very worried about that possibility. Our next part of the session is to do that information gathering. This includes thinking about the prenatal, neonatal, and postnatal history of this child. And I've noted some questions that we might ask here. Hopefully, in looking at this list, you recognize what our goal is, which is to assess, well, could there be an acquired cause for the hearing loss or a risk factor for the hearing loss in this child? In addition, we'll ask about and review the hearing history, audiological assessments, any imaging or other labs that have been done so far for this child. Next, we'll take a thorough family history. And we know going into this session that the family reports a negative family history of hearing loss. And this is our pedigree or family history diagram. It just puts everybody out on the playing field to get us a view of everyone in the family. And here is the patient that we are evaluating. He's got two older sisters who are normal hearing. The only person known to have hearing loss is the grandmother on the dad's side, who's noted to have a hearing loss in her 60s that we would consider possibly an age-related hearing loss. In addition to asking about hearing loss history, we're also going to assess for some of those referral red flags we mentioned earlier, things like renal condition, pigmentary changes, ear pits, sudden cardiac deaths. These are recommended questions to ask for the indication of hearing loss to assess, are there possible flags that would suggest an underlying syndromic diagnosis for this child's hearing loss? And for this family, they report a negative history of all these referral red flags. The physician performed a physical exam. Notably, yep, they're going to look at this child's ears, but they're also going to look at other parts of the body, things like the neck and the skin, eyes and hair, might even look at different parts of the skeletal system, address any balance disturbances. We want to get a thorough look at that child to assess if there are any possible syndromic red flags that can be noted on that physical exam. And in putting everything together for this patient, we note that his medical history is significant just for that tonsillectomy he's had, for the delayed speech and maybe some abnormal pronunciation. He's got that negative family history, and his physical exam is unremarkable. A key component to this initial session with this family was providing counseling. From reading the referring audiologist's notes, the parents were very surprised by this hearing loss diagnosis and incredibly scared and worried about it. So as part of our genetic evaluation, we provided genetic counseling. We addressed the emotions and the fear that that family was experiencing and feeling. Notably for this family, we discovered that something that's really helpful for them is having support of their family and friends. And we introduced the idea that a support group of other parents who have children with hearing loss would be another avenue for them to explore, and offered some additional support group recommendations for them. Now that we've talked about hearing loss for this child and we put all these pieces together, we provide some education. What do we think's going on based on what we know about your child and about etiologies of hearing loss, including genetics? From putting all these pieces together, most likely this child's hearing loss has a genetic etiology. And based on our statistics, most likely it's recessive in inheritance and non-syndromic. However, could be inherited in another pattern or could be an underlying syndromic cause, like those non-syndromic mimics we discussed earlier. The next piece is to talk about options for genetic testing. And sometimes I get asked, well, what does genetic testing mean? Is it imaging? So I often will highlight for parents and providers, well, what are the steps to genetic testing? The first step is to collect a sample. Most often, genetic testing is performed with blood samples. Sometimes cheek swabs or saliva can also be utilized for the testing. The next step is the actual testing. That sample is prepared and that DNA or genetic code is read. Now, it's a whole nother lecture to talk about the types of genetic testing technologies, and what we will say at this point, and relevant for this discussion, is that there are recommendations for the what type of test we would offer the patient. In this case, for this child with an apparent non-syndromic hearing loss, the recommendation is to start with a non-syndromic, or to start with a multi-gene panel, including all genes that cause non-syndromic hearing loss, and a handful of those more common syndromes. Once that DNA is sequenced, it's kind of like a spell check of that genetic code. There's a series of computer steps that then interpret and read those differences in the code. And ultimately, there's interpretation that occurs and a report that gets sent back to the provider and the family. In discussing genetic testing options, it's important to point out and recommended to point out the possible benefits, risks, and limitations of genetic testing. For this family, we've already talked about some of the benefits. They want to have an answer. They want to know about stability or progression of hearing loss, and if there's other medical care to consider for their child. There are some potential risks to genetic testing. Maybe we don't find an answer. We find an unanticipated genetic diagnosis. And certainly there are some limitations to what we can do with genetic testing. We can't identify all types of genetic changes. We may have a diagnosis where there's limited information about a gene or a particular type of hearing loss. When we talk about, well, what are the types of testing results we might get from genetic testing, we also kind of need to introduce the idea of, well, what is a genetic variant? And in the past, and still sometimes people will use the phrase genetic mutation. We use variant as a way to say some type of difference in the DNA. And it's important to note that everybody has differences. Everyone carries genetic variants. Most of the time, these variants or changes don't cause any health problems. So we call these benign. They're just something normal in the population. In this case, we're thinking more about genetic variants that cause a specific condition. And we call these pathogenic genetic variants. Now you might wonder, well, how does the test determine which of these changes is causing hearing loss or is pathogenic and which are benign, things that don't cause any differences in health? It's important to note that many genetic testing laboratories utilize a set of standard criteria, a way to look at what we know about particular genetic variants and assess, do these cause hearing loss or not? We'll refer to these as the ACMG criteria, as they were proposed in 2015 by the American College of Medical Genetics and Genomics. And in these criteria, labs will put genetic variants into one of 5 categories. They range from, on the left here, benign or likely benign, which is these are not disease-causing variants or they're not causing hearing loss, to likely pathogenic or pathogenic, which are disease-causing. This means it's causing a hearing loss and it provides a genetic diagnosis. However, and purposefully in the middle here, this gray box is an uncertain category. We might get what we call a variant of uncertain significance, or a VUS. This is not a definitive diagnosis, nor should a VUS be used to diagnose or treat someone. It's important to note, however, that sometimes for VUS, we might have additional ways to evaluate or gather other evidence. What this means is we will counsel on the possible results of that genetic test, which include a positive result, finding a pathogenic variant, a diagnosis for the hearing loss, and subsequent recommendations would be based off of that diagnosis. We also might get a negative result. This means we didn't find a genetic cause of hearing loss in this test. Importantly, it doesn't rule out a genetic cause of hearing loss. Could be in a gene we haven't identified yet and couldn't test. Maybe it's a variant our test couldn't identify. Because of variants of uncertain significance, we also might get an uncertain or inconclusive result. It means a diagnosis hasn't yet been made, but there might be additional ways that we could investigate that variant, things like testing of other family members. Families might also want to know, and you should counsel on, well, what's the chance that we get a diagnosis, a positive test result? On average, in looking at all hearing loss genetic testing, the diagnostic yield or chance of a positive result is around 40 to 60%. Now, this yield could be higher or lower based upon specific characteristics. For example, our yield is higher in congenital profound sensorineural hearing loss, that's bilateral, compared to, say, a prelingual unilateral hearing loss. So this family opted to proceed with genetic testing, and the test results were positive for a diagnosis of AUD58-related hearing loss with 2 pathogenic variants. In disclosing these genetic test results to the family, we shared that this diagnosis is non-syndromic hearing loss inherited in an autosomal recessive pattern. That the hearing loss is either congenital or prelingual onset, mild to moderate in severity, and stable. Now, this was a great relief to this family that the hearing loss was not syndromic and expected to be stable in their child. Another thing that was very surprising to me was that the family shared what the impact of the genetic process in their adaptation to the diagnosis of hearing loss in their child. The dad said to me, when we got that hearing test result, I wanted to believe the hearing test was wrong. When I saw this genetic report, it hit me. This is real. He has hearing loss. And now that's our focus. So what was the role of genetic testing for this case? Importantly, it provided prognostic information on the hearing loss, that it would be stable over time. It informed medical management by excluding a risk of co-occurring conditions and therefore the need for additional management. And you saw how it addressed the emotional aspect of that hearing diagnosis for this for these parents and assisted in their adaptation to that diagnosis for their child. So now that you have a better sense of the detailed process that genetic evaluation and genetic testing involves, let's just review some additional case studies to understand what's the role of that process in the care of deaf and hard of hearing persons. This is case number 2. This is a 6-month-old female. She referred bilaterally on her newborn hearing screen, had a diagnostic ABR that showed she has a mild to moderate sensorineural hearing loss. And she's seeing you as an audiologist for behind the ear bilateral hearing aids, which are going great. It's the first child of her parents. And you know from talking with them and asking questions that they have a negative family history of hearing loss. Based on the guidelines, we make the recommendation for a genetic evaluation, which the family is interested in pursuing. They come for that evaluation. The patient is doing really great with the hearing aids. The parents are very happy. They're just interested in learning a little bit more information about the hearing loss in their child, and in particular, what's the chance of future children with hearing loss? We took a thorough family history, which was negative for hearing loss and other syndromic red flags. She had a physical exam, which was unremarkable, and we know her medical history doesn't include any hearing loss risk factors. The family proceeded with genetic testing for hearing loss, which did identify a genetic diagnosis of hypoparathyroidism, deafness renal syndrome, or HDR, due to a likely pathogenic variant in the GATA3 gene. Now, this might not be a syndrome that you're familiar with. It's an autosomal dominant condition with the key features, as the name suggests, hypoparathyroidism, deafness, and renal disease. Interestingly, only about 2/3 of people will have all of the features of this condition. And for about, and hearing loss is the most common feature seen in over 95% of people with this diagnosis, and is often the first sign of this condition. The hearing loss can be incredibly variable, as can the renal disease. Hypoparathyroidism, if left untreated, can cause downstream effects like muscle spasms. It can cause seizures and sometimes cardiomyopathy. In the results discussion with this family, we reviewed those key features and discussed the need for that patient to follow up with endocrinology and nephrology to assess for the other features of this condition. We also made the recommendation to continue to follow up with audiology, as some persons with this condition can have progression of their hearing loss. As this couple was interested in recurrence risk, what's the chance for future children with hearing loss, we further discussed that this is an autosomal dominant condition. If you that can either be inherited from a parent who also has the condition or de novo. Given that they are interested in reproductive risk, and if one of the parents also has this condition, they would be recommended some medical follow-up. The parents did testing for this variant and were found both to be negative for the variant. What this means is that the variant is de novo in their child, or new. It's a new change that has occurred. This has a significant impact on the reproductive counseling for this family. Had it been inherited from a parent, they would have a 50% chance of having another child with this condition. However, as the variant is de novo, the chance of another child with this condition is drastically reduced to around 1%, given the chance of something that we call gonadal mosaicism, which means maybe there's a portion of, say, the egg cells in this mom that carry this mutation. So what was the role of genetic evaluation for this family? It informed medical management by identifying co-occurring conditions and allowed for appropriate follow-up to occur, hopefully prior to the onset of downstream complications. Additionally, it informed recurrence risk for future pregnancies for this couple. Let's look at an adult with hearing loss. And this is a 38-year-old male who's coming to the clinic because he's feeling some difficulties in hearing that he first noted around the start of the COVID pandemic. He reports that he has two older siblings who in their 40s were diagnosed with hearing loss. However, they felt like maybe it was because they had some occupational noise exposure. This patient is a computer coder and therefore doesn't have any occupational noise exposure risk. He also reports he's got a pretty unremarkable medical history. He's happy and healthy and takes no medications. Here is his audiogram revealing a low frequency sensory neural hearing loss rising to normal. It's kind of an interesting shape. And given that he has really no other hearing loss risk factors to explain this, he was recommended and referred for a genetic evaluation. In that genetic evaluation and taking that thorough family history, and again, here's our patient, he's 38. He's got two children under the age of 10. We do note those two older brothers who are known to have hearing loss, as well as two maternal uncles who are reported to have an adult onset hearing loss. Interestingly, they suspect this, he suspects his mother also is hard of hearing and probably should wear hearing aids. However, she's quite stubborn and really doesn't follow up with her audiologist. Additionally, there's a few other more distant relatives reported to have a congenital hearing loss. In looking at this family history, it seems to suggest an autosomal dominant pattern of hearing loss, although these other relatives with hearing loss could presumably have other causes of their hearing loss. I'll also note that the physical exam for this patient was unremarkable. What's important to note for the education and counseling of this patient, that low frequency hearing loss is characteristic of a particular gene called WFS1, where first presents as that low frequency hearing loss, but eventually progresses to impact all frequencies. What you can see here on the right is that progression begins sometime around age 40, which does really seem to fit with the narrative for this patient's brother and uncles of their ages of onset. The patient did want to proceed with genetic testing. He was hoping for information for himself as well as his two young children. And to no surprise, he was found to carry a pathogenic variant in the WFS1 gene, consistent with his low frequency hearing loss. At his results discussion, we discussed that this was a dominant hearing loss gene, but non-syndromic. It does cause a progressive sensorineural hearing loss, with recent studies showing that the greatest rate of progression of hearing loss is sometime between 40 and 45, which is about the age that he is. He was interested in knowing what this meant for his daughters. The age of onset of hearing loss in this gene is variable, sometime in the first or second decade. Because this is an autosomal dominant gene, each of his children has a 50% chance of inheriting this variant. We discussed that we could do genetic testing for his children to determine if they carry it, which they pursued. And only his 8-year-old daughter was found to carry the variant. Therefore, we made the recommendation for the daughter to have an audiogram and continued audiological screening. However, his son was negative for the variant. I will point out that other family members of this patient are interested in genetic testing, and this is in progress. The role of genetic testing for this family, it provided some guidance for this patient and his audiologist based on the natural history and progression of the WFS1 gene and hearing loss. Additionally, it helped us to identify at-risk variants and allowed for tailored screening. Oops. Our fourth patient is a 9-month-old male. He's got a congenital profound sensorineural hearing loss and a negative family history with 2 older siblings who are normal hearing. He was recently seen by the cochlear implants team to discuss the option of cochlear implantation. However, the family isn't quite sure if they wish to proceed. The team recommended a genetic evaluation, which they felt might be helpful in exploring a little bit more about the hearing loss in this patient. At that genetics evaluation, we note that the clinical history of this patient also includes delayed motor milestones for walking. This patient started walking around 18 months, and the family feels he does kind of still have some balance problems. The family wishes to proceed with some genetic testing. They want to guide care and are thinking about the possibility of future children with hearing loss. The genetic results came back positive for a genetic diagnosis for Usher syndrome type 1B with 2 pathogenic variants in the myo7A gene. In discussing these results with the family, we shared that this diagnosis, Usher syndrome type 1B, is an autosomal recessive condition that presents with a congenital hearing loss consistent with that in their child. In addition, there's a progressive vision condition called retinitis pigmentosa that begins in early childhood and results in the gradual loss of the visual field and kind of a tunnel vision, as you can see here. Most people with Usher syndrome type 1 are considered legally blind by the time they're in their 40s. In addition, people with Usher type 1 will often have vestibular dysfunction, which shows as delayed motor milestones like that seen in this patient. Given the diagnosis of Usher syndrome, this was an incredibly emotional diagnosis for this family to receive. And they were incredibly, of course, upset about that diagnosis and really wanted some guidance on how to discuss this with their family and friends. They felt like that was going to be incredibly challenging, as well as discussing it with their children and eventually this child when they're old enough. We discussed the importance of having other people in the Usher syndrome community to discuss these things with and recommended some support organizations, as well as local supports through the Deafblind Project. We recommended that the family establish care with ophthalmology given the eventual onset of that retinal condition. In addition, this diagnosis had a profound impact on how they viewed what the next steps would be for audiological care. In this case, we shared that cochlear implant outcomes for this gene are favorable, with the best outcomes, of course, being for an earlier age of implantation. And given that this child would eventually have likely be legally blind, they really felt this was the call to action to proceed with the cochlear implants for their child. The role of genetic testing for this family was to guide the treatment and the habilitation decision making. It informed medical management, including a referral to ophthalmology, and allowed us to connect this family to other resources and support given the syndromic diagnosis. Our final case is a 5-year-old male who was identified around 4 years old with the following bilateral high-frequency sensorineural hearing loss. There's no known family history of hearing loss. However, this patient is adopted and there's limited information on biological family members. We do know that the patient passed their newborn hearing screen bilaterally and had a negative medical history for hearing loss risk factors. He's also had a normal MRI. In chatting with the audiologist, the family had already read about genetics of hearing loss, and they were wondering, we don't know anything about their biological family. Can we still pursue genetic evaluation and testing? In discussing with their audiologists, the parents' goals are really just to get their child caught up and ready for school. They're going to try some hearing aids. They were talking about other cochlear implant options if needed. But as part of that collaborative care, the family is really interested in knowing, could there be a genetic cause identified to guide our current and future care for this child? So the audiologist is correct in referring for evaluation, and we assured the family that an evaluation, including genetic testing, can still be performed even if there's limited or no family history information. We counseled on the possibility of things like variants of uncertain significance, in particular, that it might take more time to resolve those variants of uncertain significance, given we didn't have the option to test family members. Ultimately, the parents felt the possible benefits of the genetic testing far outweighed their concerns for the uncertain results, and they proceeded with the genetic testing for the child. And the testing results came back negative. It's important to note for this family and anyone who receives a negative genetic test for hearing loss that it doesn't rule out that hearing loss couldn't be genetic. Maybe that hearing loss is due to a gene that we don't know about and couldn't be tested. Maybe it's a variant that our testing technology cannot identify today. What this means long-term for this patient is we recommend a return visit in approximately 2 years. Maybe there are new testing technologies or new genes that we could test for in this person. We'll also want to assess, has there been any changes to the medical history or possible symptoms for this patient that might make us think about testing additional genes? We also recommend to continue their routine care with audiology and otolaryngology. In this case, continue the discussions, follow the recommendations of your audiologist. In the absence of a genetic test, we always have the current clinical presentation to guide audiological care and management. So what was the role of testing and genetic counseling for this family? It did provide a space for the family to talk about the possible genetic causes of hearing loss in their child, and allowed us to emphasize that with a negative genetic test, the importance of continued care, both with genetics and with their audiology provider. Additionally, this family, while disappointed with the negative result, also viewed it as an opportunity for them to be involved in research projects to try to identify new causes of hearing loss. And they repeated several times that if there was any way that they could help those things move forward, they would be interested. I hope that in this series of case studies, you've got your got your wheels moving on how you could incorporate and discuss genetics within your audiology practice, with the overarching theme that a genetic diagnosis allows us to tailor our care for deaf and hard of hearing persons. Well, in a pre-genetics era, we followed kind of a one-size-fits-all approach, where hearing loss is identified, we performed subsequent laboratory studies or imaging, and maybe achieved a diagnosis for some. With our current options for genetic testing and evaluation, we can tailor care where hearing loss is identified. We first perform that genetic evaluation and testing, which hopefully identifies a genetic diagnosis and provides tailored counseling and workup based on that etiology. Today, we have reviewed that genetic etiologies are the most common cause of childhood onset hearing loss and contribute to a significant proportion of adult onset hearing loss. We've highlighted how genetic evaluation and testing can benefit patients, their families, and their healthcare providers, including audiologists. It can tailor our medical management and follow-up based on the genetic etiology. It can provide anticipatory guidance on hearing loss progression or stability, facilitate amplification, communication, and education decisions, initiate cascade testing of family members who are at risk for hearing loss, and importantly, provide psychosocial counseling to aid patients and families in adaptation to hearing loss. I'll conclude by saying that there are so many future opportunities for hearing loss genetics, including opportunities for collaboration among patients and families, clinicians, and researchers. With that, I'll acknowledge the patients and families and healthcare providers we've been able to collaborate with, my colleagues on the MRL hearing team and Iowa Otolaryngology Department, and the organizers of this conference. I want to end with a few resources for you. One is to scan a QR code where you can get a handy pocket guide with some of this information and key fun facts that you can share with families, as well as a few websites if you want to learn more about genetic counselors or find a genetic counselor in your area. With that, I'll show my references just quickly. And thank you for your attention today. I put my email on here, so feel free to reach out now or in the future should you have any questions.